respected chairpersons, senior teachers, my dear colleagues and students. The topic assigned for me is the clinical approach to shoulder pain. So whatever I am going to tell are very familiar. All aspects are to this audience because this is a routine case that we are seeing in the OPD and we are managing in our clinical life. But my only attempt is only to form an algorithm, that's all. We'll see. Synonymously, shoulder means there is a sense of responsibility. And it is considered as a sense of strength, endurance and responsibility. Shouldering responsibility. So in fact, look at the picture of the person, the legend from Greek mythology projected here. Some of you can identify that it is Atlas. He was cursed by the supreme god Zeus to shoulder the weight of the entire heaven on his shoulder. So that is why the Atlas is considered as an icon of responsibility, endurance and strength. But imagine the pain he is suffering because of that curse. So let me come to the topic. Shoulder pain is one of the most common presenting complaint in the PMR, ortho and family medicine clinics. And it is, a Scandinavian study has shown that it accounts for about 18% of sickness absenteeism. And it is mentioned here by Dr. Srijit that where the mobility is actually at the stake of stability. There is a simulation in one of the slides I have seen. A golf ball is actually located in a narrow stirrup. That is a way. So it's a narrow spectrum of symptoms, but a broad list of etiology. The person will present with either pain or instability or with stiffness. But the reasons, etiology can be very broad. So it's a narrow spectrum of symptoms, but a broad etiology of it are there. Conventionally, we do we take the clinical history. When we do the physical examination, then we do the joint examination. When we do the joint examination, examine both joints, irrespective of the complaints the patient is saying. Then you do the irrelevant blood investigations. You write starting from the CBC, ESR, then as the case warrants, we move on to the advanced rheumatological investigations. And if necessary, and there is an effusion present, synovial fluid is aspirated and is subjected for the microbiological, biochemical and cytological studies. And if necessary, we will subject it for a polarizing microscopy. Then imaging studies, which is already covered here, right from X-ray up to the MRA. Then diagnostic interventions, we give diagnostic blocks, the GH, the glenohumeral blocks or the acromioclavicular blocks with the lidocaine to confirm the diagnosis. So what are the objectives of my presentation? To formulate an algorithmic clinical approach to shoulder pain. So to learn the 4 steps, 4 questions and the 4 red flags. Mainly based on the paper presented by the Jami Hind and Govt Aziz. So what are the 4 steps? We consider the shoulder case as trauma, step 2, referred cases, then extra glenohumeral and finally glenohumeral. Step 1, in the trauma, invariably there will be a history of trauma is there. And with the visible deformities. Visible deformities means you can identify a sulcus sign with an anterior dislocation of the shoulder, or the shoulder will be persistently internally rotated in the posterior dislocation, and the visible deformities produced by the shoulder will be evident there, and it is very easy to localize the site of pain also. And the patient will invariably have abnormal movements, and abnormal range of motion will be there, and with appropriate imaging we can diagnose most of the situation. If the imagings are negative, then you go to the step 3, that is soft tissue damage, that is extra glenohumeral condition. Then step 2 is very important, the referred causes. In referred causes, the pain is actually poorly localized. And the range of motion will be absolutely normal. And the character of the pain, it is dull aching, sharp shooting or radiating pain. The pain will be having more or less a neuropathy character. And the patient will be having more symptoms in the hands or in the fingers. So the fingers are more having symptoms than in the hand. We consider the mononeuropathy as a possibility and peripheral neuropathy in the hand symptoms. And the conditions where the patient is having agonizing shoulder pain and subsequent the subsidence of pain, the patient will be having weakness. That is a classical presentation of Parsonage-Turner syndrome or the neuralgic amyotrophy. That is also an important cause of shoulder pain. Then coming to the visceral causes, that is very important. The gallbladder, spleen, and in such pathologies, either a GB gallbladder cholecystitis or splenic infarction, the patient will be having pain in the respective shoulders, in the right shoulder, in GB pathology, and left shoulder in splenic pathology if it is a situs solitus, and it can be reversed in situs inversus. Then basal pneumonia is an important cause for shoulder pain, then subdiaphragmatic abscess, hepatic abscess, all these can radiate to shoulder. Shoulder pain associated with dyspnea, it is indicative of a myocardial ischemia or the myocardial infarction. And if associated with obvious loss of weight and the patient got obvious features of suffering, it could be the feature of a malignancy. Then coming to the step 3, the extraglenohumeral, 3 pathologies there, acromioclavicular, long head of biceps, and scapular. And first one, the acromioclavicular. When you ask the person to point the site of pain, the person will definitely point using a tip of finger and they will touch the acromioclavicular joint. That is what you call finger sign. And here, when you elicit the range of motion, they are having maximum pain beyond 120 degrees of abduction, because we all know that the painful arc is in the 60 to 120 range, but here in the acromioclavicular pathology, the pain will be maximum in the beyond 120 degree. And there is a reduced adduction test which can be made out by the classical scarf test. And the focal signs of inflammation will be there in the joint, and it can be confirmed by an AC, lidocaine ejection test. And if the imaging is normal, as I told, the soft tissue injuries, we move on to the step 3, extraglenohumeral. The second step is the long head of biceps. And the classical speed test, the resisted abduction and the resisted supination, that is ergasence test, will be positive in long head biceps, and MSK USG is confirmatory with the hyperechoic signals from the tendon with the presence of fluid around the tendon. And in this context, there is an important test that's mentioned in that paper. I think it is worthwhile to mention here. That is the NFL touchdown sign, where you ask the person to elevate both hands over the head and touch like this. If the person can do this without producing any pain, then that rules out most of the glenohumeral and acromioclavicular pathology. But the severe pain indicates RC tendinitis, the rotator cuff tendinitis or arthritis, and the weakness can be caused either by an RC tendon tear or a muscle atrophy or a neurological pathology. Neurological pathology, you have to consider axillary neuropathy or C5 radiculopathy or proximal upper brachial plexopathy. And the limited motion in the NFL test consists of arthritis or adhesive capsulitis, where the imaging can help you. And the patient who has sustained trauma will not even attempt the maneuver. So in that way, the NFL touchdown test is very useful. And regarding the scapular, there is an altered scapulohumeral rhythm mentioned by Dr. Srijit in his presentation on biomechanics. The 2:1 ratio movement between the glenohumeral and the scapulohumeral movement will not be there when the scapula is involved. And you can identify scapular winging. It can be a medial winging or lateral winging. Medial winging in the serratus palsy and lateral winging in the rhomboids paralysis. And wasting of the scapular muscle, the suprainfraspinatus and rhomboids, the medial muscle, and the lateral muscle are the serratus anterior. But at times, the scapular pathology may be difficult to isolate. And coming to the glenohumeral as such, there are 4 pathologies described: pain, stiffness, instability, and osteoarthritis. Pain, before I mention acromioclavicular joint, the person may use the tip of finger to touch the point of pain, but here they may use the whole palm to localize pain. That is called palm sign. In palm sign, if there you consider glenohumeral, and finger sign you consider acromioclavicular. And the stiffness, there is a positive Codman sign doing the classical Codman's test. And instability, as mentioned already by previous speaker, can be anterior, inferior, or posterior instability. The drawer signs, the respective drawer sign, anterior or posterior, and the respective anterior or posterior apprehension test will be positive. And osteoarthritis imaging will definitely help to demonstrate the presence of osteophytes with the capsular thickening and reduced joint space. And there are 4 classical questions you should ask the person with a suspected glenohumeral injury. What is the major complaint of the patient, and what is the age of the person, and what is the type and level of activities, and what is the duration of the problem. We'll see one by one. What's a major complaint? If the complaint is pain and loss of power, it is indicative of an RC, rotator cuff tear. But instability is the more problem. It is a indicative of either a trauma or associated with a benign hypermobility syndrome or the syndrome conditions where the instability of the joints are present, like E-laced annulus. But if the stiffness is a major problem, you think in terms of adhesive capsulitis or osteoarthritis, where imaging can differentiate the two conditions. Where it's negative, the imaging is totally normal in adhesive capsulitis. What is the age of the patient? When the patient's age is a child and adolescent, presenting with shoulder pain for the first time without history of trauma, you think in terms of a benign hypermobility syndrome. But if there is history of trauma, you give more importance for that. A similar case in young adults with the sports injuries. Middle-aged, more in favor of an RC, but old age adhesive capsulitis is an important condition you have to consider. What's the type and level of activities? The young throwers, especially the javelins and all, internal impingement is a very important condition you have to consider. Just like the marathon swimmers, swimming for longer distances, and overhead sports like volleyball, all these conditions, RC may be the involvement. Then spinal cord injury, that usually we observe in our wards, especially people with the high thoracic and cervical. Most of the time, for the effective ambulation, they are depending on wheelchair, where excessive use of shoulder, and without much strengthening of their shoulder muscles, they can develop RC pathologies. But what is the duration of the problem? Acute pain with no history of trauma. It is indicative of an overuse or a tendinitis. But if there is a instability and it is painless instability is indicative of a dislocation, where the patient is having, as mentioned earlier, there is a defect of the head of humerus, the Hill-Sachs lesion, or with the glenoid, the Bungard's lesion. That makes them prone for recurrent dislocation. Then throw shoulder. Classically, the pathology described is a labral tear or an articular side supraspinatus tendon in acute tear. That is the most common pathology that described in throwers. There is a tear of the supraspinatus tendon towards the articular side, or there is a labral tear. Overhead workers with the shoulder pain, but there is no stiffness, is indicative of a rotator cuff tear rather. But you consider calcific tendinitis in which situation? When there is a midnight pain, especially in sedentary middle-aged females, more seen with females, you have to say consider the possibility of a crystal-induced tendinitis. Pain and evolving stiffness in middle-aged with the past history of shoulder symptoms. They are having pain there for longer time, then slowly evolving stiffness, usually associated with, as we know, the rearranged HbA1c, you consider adhesive capsulitis. And pain and evolving stiffness without past history of shoulder problem. All on a sudden it is evolving, then osteoarthritis, where the imaging will give an idea. But if the thing is there for a longer time, and then evolving with the stiffness, then you consider the combination of RCT with the adhesive capsulitis. This is the way we are routinely doing in our practice. And finally, the 4 red flag signs. Pain and stiffness with the loss of weight, as already mentioned, primary malignancy, where the superior sulcus tumor, the Pankos tumor, which is advancing to shoulder, is a very important condition, or a metastasis. And the nocturnal pain, which is relieved with aspirin on NSAID, a benign tumor, osteoma of the scapula or the humeral head, is a very painful condition, and classically the pain can relieve with the NSAID. That will give you an idea. And then X-ray can very well demonstrate that condition. And focal signs of inflammation if the shoulder is showing with the fever, the systemic symptoms, fever, chills, rigors, that is indicative of septic arthritis, where a blood investigation can give you the clue. There will be polymorphonuclear leukocytes with the raised GSR, and all the inflammatory parameters will be raised. And associated with any seropositive or seronegative arthropathy. That is, usually we see the stiffness of shoulder in a patient with ankylosing spondylitis, because directly the appendicular skeleton is not involved in this condition, but because of the affection of the the joint between the ribs and the vertebra, the costovertebral and the sternocostal joint, acromioclavicular joint and sternoclavicular joint involvement, it will be reflected in the shoulder, and the shoulder will be stiff. And the mixed lesions, whether you had a combination of instability with the RCT. So these are the 4 situations where the red flags you have to consider, and you have to investigate the patient further and manage accordingly. And shoulder and chronic pain, finally. We all know the person is persistently coming to OPD with the shoulder pain more than, say, 6 months, like that, then we consider the chronic pain as a possibility, and there the classical myofascial pain syndrome affecting the C5 myotome, where the patient will be having pain in the almost all C5 myotomes, that is supra-infraspinated, deltoid, biceps with multiple trigger points and tender points, where the classical management for that condition only will relieve the condition. Or the patient is having widespread pain with 18 tender points described, out of which 11 are positive with the chronic sleep dysfunction, the REM sleep predominance, we consider fibromyalgia as a possibility. In all such situations where a trauma, especially an RT, is associated, you have to consider litigation behind persisting symptoms, and such patients, you should approach them accordingly. And so even malingering also, you should consider in certain patients as the last possibility of resistant shoulder pain. So let me conclude. Shoulder pain is a common and clinical condition in our practice. And a detailed history, a physical examination, and a relevant investigation shall cleanse the diagnosis in most of the case. But an algorithmic approach that I have just now presented make the clinical evaluation more focused and comprehensive. That actually classifies the lesion in a compact form and will enable you to memorize easily. And this is my classical reference. And my objectives were this: to formulate an algorithmic clinical approach. Remember the 4 steps, 4 questions, 4 pathologies, and 4 red flags. Thank you.
Thank you, Dr. Santhosh Raghavan. So these conferences have become almost like a national conference now. Ramamurthy, please.
Thank you, sir. Thanks for remembering. Question to Dr. Santhosh. It's a wonderful presentation. With reference to rotator cuff injury, what's the classical clinical test and treatment?
Okay. For the rotator cuff, the most commonly implicated tendon is the supraspinatus. So we use the Hawkins test. Then so many named tests are there. The empty can test. Empty can test is the most commonly one we use in our. We ask the person to abduct in the 90-degree position. When you internally rotate, then you ask them to further abduct it against resistance. Empty can test. Then there is something called thumbs up sign, thumb sign. I could find more than 100 tests for this RCT and all. But this is the most common test we use in our OPD.
All the presentations were very good. Again, not a question, an observation as a practitioner, not as a faculty. In the post-COVID scenario, left-sided painful shoulder syndromes are on a rise. This is my observation. Previously, I believe that it was the right side, which is the dominant side, which was more important. Now, left-sided, it is likely to be associated with the COVID vaccination. And faculties and the house, please take a note of it and please observe. This is my observation since past 3 years. Left-sided is, especially periarthritis, and tennis elbow, always elbow, everything in the left side, left upper limb is on a rise now. Please observe and see.
Dr. Charvagan.
Dr. Santhosh, algorithmic approach is very important because more often we get misdiagnosis from ortho. Just like cervical radiculopathy can be easily diagnosed, will be sent as sarcastic capsulitis. So the algorithmic approach is very nice. You are done a good job. Very nice presentation. Systematic, good.
Dr. Hasna Ali. Dr. Hasna. Right. Dr. Surendran. I think the time is running short.
The presentation of Dr. Santhosh was excellent, and I don't have to add much, but sometimes people used to miss the complete tear of rotator cuff and diagnose it as paralysis of the deltoid sometimes.
I have, I think I will be soon concluding. Dr. Sridhar can you just quickly explain the difference between kinesiology and biomechanics?
I said that I am I'm very poor in biomechanics. Kinesiology mainly is the movement, sir. Biomechanics includes some, apart from movement, I think George sir, George Thomas sir.
And what about that cricket here? Yeah, please come, please, quickly.
Thank you, Srijit, and thank you, Chair. So the difference is very simple. In biomechanics, you consider only the mechanical elements, forces, torques, angles. In kinesiology means when you include anatomy. So kinesiology is actually part of biomechanics for us, but if you look for definitions, kinesiology means the science of movement. So we describe what we describe in anatomy is kinesiology. And when we study the forces, use mechanics, apply mechanics to the anatomy, that is biomechanics. Is that so?
You remember many years back, there was a controversy with a Sri Lankan cricketer, bowling, and at a particular time he will throw. And they were analyzing for 1 year in Australia or something. Is it possible to highlight that aspect of the biomechanics?
What aspect, sir?
You never mentioned about cricket.
Oh, yeah, circumduction. Okay, circumduction is the most abnormal movement. And actually, that is more injury prone, sir.
He was flexing his elbow.
Yeah. Okay. Bumrah is
Bumrah's bowling, that is also under scrutiny for some time, as sir has mentioned. And the elbow flexion was a problem with the Muralidharan. And he was continuously analyzed for nearly 1 year in the kinesiology lab of Australia. And finally certified.
You want to ask anything?
Sir, I just want to add on one point. I had a patient in ASI, a young chap, 27-year-old, with bilateral shoulder pain, excruciating pain, finally turned out to be a lymphoma. Just always, when you get bilateral pain, just think of the other possibilities. That point I wanted.
And vis-a-vis a tertiary center or other centers. We cannot think of the imaging services in a primary health center situation for shoulder.
That's very simple. I've been encountering this question for a long time. 70% of shoulder pathologies can be picked up or ruled out by an X-ray itself. 70%. And most important thing is you have to be very careful in identifying the soft tissue. Now 30%, of course, in X-ray you won't get it, but that is of course for the next level. But in 70%, you can.
Thank you. I think the time is up. We can conclude from my, on the other side there are two ladies. I'm excused between two ladies. So Dr. Srikala, come to you.
Thank you. Even though we had a few technical glitches and lost a few minutes, we could conclude in time, I think. So thank you, Dr. Srijit, Dr. Manoj, and Dr. Santhosh Raghavan. Thank you.
May I request Dr. Hariharan sir to kindly present a memento to Dr. K. Srijit. May I request Dr. Srikala ma'am to kindly present a memento to Dr. T. Manoj. I request Dr. Uma ma'am to kindly present a memento to Dr. Santhosh K. Raghavan. I now request former President Kerala Chapter IAPMR, Dr. Santhosh Babu sir, to kindly present a memento as a token of our appreciation to chairs of the session, Dr. Hariharan sir, Dr. Srikala ma'am, and Dr. Uma ma'am. We extend our heartfelt thanks to all the speakers for their insightful presentation and to the chairpersons for skillfully conducting the session. Thank you all for your active participation.